Very good morning, all the medicals. Let's start with the ENT segment. The first MCQ, identify the clinical test. What I am showing you in the slide, I am keeping the tuning fork over the pinna, then I am keeping behind pinna. I am comparing bone conduction against air conduction. Am I understandable? So what I am doing the test of Raynaud's. Just remember, in Weber we are comparing right ear from the left ear. Here I am comparing ear AC against bone conduction, air conduction against bone conduction. Let us learn three important points for your upcoming FMGE examination. Raynaud's positive, Raynaud's negative, or examiner can ask you false negative Raynaud's. Just make a concept whether either they will ask you Raynaud's positive, Raynaud's negative, or false negative Raynaud's. What is Raynaud's positive? Raynaud's positive is amplification positive. What do you mean by amplification positive? AC better than BC, which will be in three human being: normal, sensory, and neural. Normal, sensory, and neural. Raynaud's negative. What do you mean by Raynaud's negative? Amplification negative. Bone conduction is better than air conduction and is only a feature of conductive deafness. So Raynaud's positive, Raynaud's negative. Raynaud's positive is amplification positive, Raynaud's negative is amplification negative. Next important concept, just remember, what is false negative Raynaud's? If there is a lack of masking, there can be a false negative where the bone conduction of the opposite ear, the opposite ear is helping with the which conduction is there in the false negative Raynaud's? Bone conduction. Clear? It is because of lack of masking. It is seen in severe unilateral sensory neural deafness. So just revise everybody with me. Raynaud's positive, normal, sensory and neural. Raynaud's negative is conductive deafness, and false negative Raynaud's severe unilateral sensory neural deafness. Entering to the next MCQ, question number 60. Now, question number next two. Question number 2, 68-year-old diabetic patient with black foul-smelling discharge from the nose. So, as a damn student, what you will do? You will combine these two words: diabetic patient and nasal cavity. So, he is talking about mucormycosis. There is a black discoloration, evidence of necrosis. The diagnosis is here mucormycosis. Clear? So diagnosis in this MCQ will be mucormycosis. Drug of choice, liposomal amphotericin B. And what is the beauty of this mucormycosis? It blocks the blood vessel. Always remember, this have a love for blood vessels. It have a love for nerve fibers. So therefore, blood vessels block, no bleeding. So in the last stage, when this is necrosis, every artery is blocked, so there will be no bleeding, no pain, no bleeding, no pain. These are the important keywords. So mucormycosis is very important point for your upcoming examination. Diabetic patient. Can I make a flowchart for you in your FMGE examination? If the word diabetic is there, and three possibilities. If the MCQ is from ear, it is mucormycosis. MCQ from ear, MCQ from ear, from nose, or from oral cavity. So mucormycosis will be under the heading of nasal cavity. Mucormycosis. MCQ from ear, it will be malignant otitis externa. Oral cavity, it will be your Ludwig abscess. So these are the three important points. You should be confident. Coming to the next MCQ. A patient with head injury. Again, but all these ones, listen to me. Focus on the keywords. What are the keywords? Bluish discoloration over the mastoid. What is this one? Battle sign. Bleeding from the external auditory canal. Complaining of the hearing loss. With normal facial nerve. Bleeding from the external auditory canal. Battle sign. It means somewhere the examiner is showing you, is giving you a clinical scenario of skull fracture. But which skull fracture? Now you tell me, which skull fracture? This is bleeding in the canal. It means my external ear and middle ear is involved. So when the trauma is coming from anterior superior, what we call it as longitudinal fracture, it is here external ear, middle ear damage. Just remember, I am writing a formula for you. Longitudinal fracture is equal to external and middle ear damage. If there is a transverse fracture, somebody hitting you from behind, very less means 20%. Longitudinal fracture is seen in 80%. And if somebody is hitting you from behind, it directly damages the midline, it damages the inner ear. So let us make a nice concept better. If there is a longitudinal fracture, there will be trauma to external ear, trauma to middle ear. When there is a transverse fracture, there is a trauma to inner ear. So from here, I will just make a diagnosis: longitudinal fracture, transverse fracture. Longitudinal is around 80%, transverse is very less common, that is 20%, external ear, middle ear. Therefore, external auditory canal bleeding. There can be CSF in the middle ear. It will be conductive deafness. There will be minimum vestibular symptom. But in transverse fracture, if you compare, the inner ear is damaged. When the inner ear is damaged, so you will be having vestibular symptoms present, and patient will be having sensory neural deafness. So this is the way we differentiate longitudinal from transverse fracture. Then coming to the next one, investigation of choice. The examiner is asking you investigation of choice for a 12-year-old male child with polypodal mass which bleed. Now, very nice concept. Rule of the game: whenever there is an image-based MCQ, first focus on the image. What I am showing you, can you appreciate a typical presentation of a tumor, polypodal mass with blood vessel, angiofibroma? So what is, which bleed on touch? Young boy, angiofibroma. Even if the examiner have not given the slide, you can make a diagnosis of angiofibroma, which will be the investigation of choice. CT examination, yes, we will do. Contrast enhanced CT, these are confusing terms. Biopsy, not at all. No. Which investigation is contraindicated in this patient? Answer will be biopsy. CT with angiography, yes, we can appreciate the extent of the tumor. Among the given confusive choices, the D option is the best option. Am I understandable? This is very important topic. Angiofibroma, expecting on MCQ. Most common site is sphenopalatine foramen. It is 14-year-old boy. No bleeding is there, or with a slip of tongue. Patient present with bleeding. Angiofibroma. Am I understandable? Sphenopalatine foramen, 14-year-old boy. Next to expected MCQ, they can ask you frog face deformity. Or they can ask you Hallman-Miller sign. What is Hallman-Miller sign, beta? There is a tumor. It push which wall of the maxillary sinus? It push the posterior wall of the maxillary sinus. So the posterior wall is bending down. We call it as Hallman-Miller sign. Important point. No biopsy. Never ever. There is a tumor of blood vessel, so there should be no biopsy. What is the treatment of choice? We have to remove surgical in toto completely. We have to remove the tumor. Clear? Done. Coming to the next one, type of incision. What I am showing you, I am showing you a incision at incisura terminalis. This area. This is my tragus. This is my hallux. In between incisura terminalis. If I give an incision, we call it as Lampert incision. What is this known as? Lampert incision. If I give an incision behind pinna, like you touch your mastoid. If I give incision here behind mastoid, is known as post-auricular incision. This is known as post-auricular incision. Then Lampert. What is the importance of this Lampert incision? This is used for pediatric patient. Done. Coming to the next one, next MCQ. A 35-year-old patient with epistaxis in emergency, which was not controlled by the nasal packing. So patient is not responding to the initial method. So what is the next management? Ligation of external carotid, internal carotid, not at all. Will you ligate sphenopalatine or maxillary? Obviously, I will go for sphenopalatine first. Now, so it is an artery of epistaxis. Again, an important topic. In epistaxis, they can ask you which is the artery of epistaxis. One important point. You should be confident of litus area, retrocolumnar vein, Woodruff plexus, and one important method, Trotter's method. What is Trotter's method? Trotter's method is used in epistaxis. What is Trotter's? You pinch the nose and spit out the blood. This is known as Trotter's method. They can ask you what that TELESPA stand for. Again, important MCQ. TELESPA. TELESPA is transendoscopic ligation of sphenopalatine artery. Transendoscopic ligation of sphenopalatine artery. This is again one of the potential MCQ. Done. Coming to the next one, a child underwent tonsillectomy after surgery, shifted to recovery room where he started bleeding. On examination there was clot. What is the next step? What I'm showing you, I'm asking you hemorrhage, bleeding, one of the most important complication of tonsillectomy. Tonsillectomy is of three types. Bleeding, that is hemorrhage after tonsillectomy, is of three types: primary hemorrhage, reactionary hemorrhage, and one is secondary hemorrhage. One MCQ expected from these three formulas. What is primary hemorrhage? Bleeding on table. When there is a bleeding on table during the surgery. What is the cause? Cause is you have done injury to the vessel. So there is an injury to the vessel. What is the management? Ligate the vessel. So primary hemorrhage is on table. It is due to injury to the vessel and we have to ligate. What is reactionary? Reactionary is within 24 hours. So within 24 hours, if bleeding is there, that is due to slippage of ligature. It is because of slippage of ligature. What is the treatment? Treatment is we have to shift the patient to OT and we have to religate. We have to religate. So in this scenario, I'm giving you typical history of reactionary hemorrhage. So the best answer will be shift the patient to OT and ligate the bleeding vessel. What is secondary hemorrhage? Secondary hemorrhage is bleeding after 24 hours. What is the cause? Cause is infection. What is the management? Management is IV antibiotics. These are three formulas. Let us revise with our primary is on table, reactionary within 24 hours, secondary after 24 hours. On which day? On which day this secondary hemorrhage is most commonly seen? So just remember, it is 5th to 7th day. It is commonly seen. 5th to 7th day, secondary hemorrhage is commonly seen. Done. Coming to the next one, 40-year-old female in ENT OPD complaining of nasal obstruction, presence of crust, foul smelling, breathing difficulty. On examination, foul smelling, black crust, foul smelling, keyword, nasal obstruction. Which of the following finding is associated with merciful anosmia? So what we are learning from this MCQ, always focus on the last statement. Last statement sometime it can save your time in the examination hall. Examiner is asking you merciful. What is merciful anosmia? Keyword for atrophic rhinitis. So this patient is suffering from atrophic rhinitis. In atrophic rhinitis, when everything is atrophic, the whole nasal cavity will be roomy cavity. Total the best possible answer in this MCQ will be option C, roomy cavity. This is atrophic rhinitis, not hypertrophy of turbinate. For hypertrophy of turbinate, which keyword should be there in the MCQ? Mulberry-like nasal mucosa. Mulberry-like nasal mucosa. If mentioned, it is hypertrophy of turbinate. Foreign body. If the examiner is mentioned the unilateral foul smelling discharge, it is foreign body. Then polyp, pearly white mass. In the MCQ, if they mention the word pearly white mass, it is polyp. Done. So answer in this MCQ will be atrophic rhinitis. That is option C, roomy cavity. Next MCQ, which of the following is a true sequence of auditory pathway? Very important potential question, but it can be repeated again. ECOLIMA. Aetna, cochlear nucleus, olivary nucleus, lateral lemniscus, inferior colliculus. Superior olivary complex is our third center. It cannot be the first one. Clear? I hope you are getting my point. Cochlear nucleus, then superior, then lateral, then inferior. The option B is best. Inferior colliculus cannot be the first one, not at all. Lateral lemniscus, again the one of the higher center. So answer in this MCQ is your B option. In this MCQ is your B option. Done. Is this clear? Coming to the next MCQ, 6-year-old child with a history of hearing loss for the last 2 months otoscopic finding, what I'm showing you blebs on this tympanic membrane. Small blebs are there. If the patient, the main symptom is hearing loss, just remember, if the presenting symptom is hearing loss, I will go for serous otitis media. And if the patient is having pain, we will go for meningitis bullosa. So the best answer in this MCQ will be patient is coming with serous otitis, hearing loss. So the option will be serous otitis media. Then this is a typical feature finding of serous otitis media. Coming to the next, a adult male while having dinner suddenly become aphonic and choking sensation. The patient is asking you what is the next step. So if the patient is having food bolus in the respiratory tract, the best is Helmich maneuver. So option D. In this we are, first we have to stand behind the patient. We put the thumb side of just below the patient belly button, and then we have to hold it tightly and push it. Just a thrust should be there. I will be highlighting this word. The force should be upward and inward into the person's belly, so that it will, you can say, push the foreign body, obstructed foreign body in the respiratory tract. This helps a lot. This is the first method. This is one of the simplest method where you can help a patient. Click. 3 important points. Cannot speak, is conscious, and is over 1 year old. So these are the important points which should be taken in consideration when you are doing Helmich maneuver. So option D will be the best choice. Coming to the next one, 42-year-old male, chronic history of bronchial asthma, sinusitis, hamster's tract. What is hamster's tract? Is bronchial asthma, nasal polyps, and sensitivity to a drug. Which drug? Aspirin. So which of the following drug will be contraindicated? Answer will be aspirin. Very old MCQ of FMGE, which I really appreciate. They can ask you, hamster's tract is due to. This is due to, if examiner asks you, this is due to, it is due to IgE release. Just remember this concept now. It is due to IgE release. Clear? Hamster's tract, along with the hamster's tract, cartilaginous syndrome. In cartilaginous syndrome, we are having nasal polyps with dextrocardia, right sided act with bronchiectasis, and one is Young syndrome if the patient is having azoospermia Young syndrome. Dextrocardia, cartilaginous syndrome, azoospermia Young syndrome. Clear? Coming to the next MCQ. External nose. Contour of the nose is maintained by. So always remember, when I draw a nice line diagram of nasal cavity, the upper one third is bony, the lower 2/3 is formed by cartilage part. This cartilage part is further divided into 2 parts, upper lateral, lower lateral cartilage. So among the 4 options, the B option, upper is 1/3 is bony and the lower 2/3 is the cartilage part. This is the basic anatomy of your nasal cavity. This, I have given you nice slides where it is clearly seen. These are 3 important parts of the external contour of the nose. Coming to the next one, often repeated question, Anayana beta, a child with a history of foreign body ingestion. The X-ray picture is shown to you. It is lateral view beta. Lateral view. On AP view, if the foreign body is showing you a circle, it is esophagus. If it is showing a line, that is trachea. When it comes to the lateral view, everything is reverse. So on lateral view, if it is a line, it is your esophagus. So in this MCQ, the answer will be your C option, because this is lateral view and it appears like a line. Answer will be C option. Okay. This is trachea. In trachea, on the AP view, it will be a line. On the lateral view, it will be a circle. But when the foreign body is in the esophagus, on the AP view, it will be like a circle, and on the lateral view, it will be a straight line. Then, sorry, I'm showing you this slide. Only motive, this question should not go wrong. Clear? So these are the view of a foreign body in the respiratory tract or in the digestive tract. Coming next, trumpet player. You are a dance student, beta. When you read the word trumpet player, we'll directly jump to which diagnosis? Laryngoscele. The examiner is showing you some swelling in the neck with trumpet player. This is air-filled cavity. This is air-filled cavity. Everybody is having a normal sacule. Sacule is a oil tank. It contains mucus gland which give you mucus to the vocal cord. But if it is obstructed and if enlarged in size, it is known as laryngoscele, commonly seen in trumpet player or those who are doing excessive Valsalva. What is the diagnosis? Diagnosis will be a swelling. On X-ray, CT, you will be appreciating a radiolucent swelling. Important question. This swelling can become extrinsic. How it can become extrinsic? By rupturing a membrane. Which membrane? Thyroid membrane. If it ruptures the thyroid membrane, it comes out into the neck extrinsic. Then what is the treatment? Surgical excision. So these are the 15 important topics. Important motive of giving these MCQs to tell you that these are must-read topics. Don't miss these points, like Raynaud's test or Weber or your laryngoscele. These all are important topics. Very best of luck, and we are confident, and what is mission? Mission this year, we have to touch 200 eminence level.